Hey team, it's Les. Thanks for joining me. And we are going to talk about the live discharge for extended prognosis procedure. This is a procedure that we've had in place for a while, but not everyone is aware of necessarily following right now these steps. So we're going to just go over the procedure. I'm going to show you this form and I'm going to show you the checklist that you can use as you're going through a live discharge to ensure that we've done all of the steps, right? We've gone through all of the procedure correctly. So the very first thing we do is as an IDG, we discuss the ongoing eligibility for our patients during every IDG meeting. This is literally what we're doing every 2 weeks when we have an IDG meeting. We should always be thinking about not just as we're getting ready to recertify someone, but always be thinking about eligibility and whether that person that we're providing care for is eligible for the hospice benefits. So we should always be looking at that. If we identify at any point, regardless of whether it's time for them to restart or not, if we identify any time that there's questionable eligibility, we need to start this process, right? And again, if we don't see any questionable eligibility, we just do our standard IDG, and recertification processes. So, the RN case manager, first of all, when we identify and we start this process, we want to contact the attending physician if there is one, right? We know that a lot of times our hospice physicians are acting as the attendings and they don't have a separate attending. But if they have a separate attending, we want to contact them, discuss the patient's questions as far as what we're having questions on their eligibility. We want to request any documentation that they may have that could support ongoing eligibility, and we want to document that conversation that we have with that attending physician. And we want that verbiage in that note to say the patient's under review for ongoing eligibility. It's very important that we don't say we're discharging a patient at this point, because once we say that we have spoken to a physician and they have said to discharge that patient, they are no longer eligible from that moment on for us to bill, right? And for us to give that 5 day notice and still be able to take care of them for that. Once that physician says we're discharging this patient, they're no longer eligible at that moment, we can no longer bill. So we need to be very careful about how we document this. And if we say something to the effect of patient is under review for ongoing eligibility, that says to the auditor or whoever's looking at that chart, yes, we recognize that we need to dive into the eligibility concerns. We're not discharging right now, but we are reviewing. The third step is again for the RN case manager. If an RN02 visit hasn't been completed, that visit should be completed in tandem with a second RN case manager or nurse practitioner. If that RN02 has been completed, the next routine visit should be scheduled again with another RN case manager or a nurse practitioner in tandem. Document the conversation with the patient and the representative that again, eligibility review is underway. The fourth step is for the PCM. If the face to face visit has not been completed, PCMs, we need to go ahead and schedule a face to face visit with the nurse practitioner. If the nurse practitioner is going to go out with in tandem with the RN case manager, then we can schedule both those for the same day and they can still do those together, but it should be scheduled as a face to face so they can put their eyes and hands on that patient as well. And then the PCM is the step 5 as well. Report your findings to the hospice physician and the CMO, Dr. Capper, along with any necessary documentation identified for final review and guidance. And then once the patient has been found to have an extended prognosis, these are the steps. So once we've kicked this up to the team physician and Dr. Capper and our CMO, right, to review that chart and to let us know if everyone is in agreement that they do have an extended prognosis and we should move forward with the discharge process. This is what that looks like. The next step is for the RN case manager. We're going to obtain an order and document it in the record that discharge planning is to begin today for expected live discharge on the date, right? And so we at least must push that out to give us time to deliver in writing, right? A discharge notice, a 5 day notice of discharge, and to have that 5 days built in so that once we get past that 5 day notice, then we can discharge the patient. So that's how we calculate that. The day that we are delivering That notification is day 0, so then we count 5 days, and then the 5th day we can actually discharge. The documentation of the discharge planning and the discharge planning coordination note. So we must put we're gonna ask the case managers then to put a note in, a coordination note in addition to that order, and there is a template in your coordination note types called discharge planning. If you use that template, it has all these pieces in there, and then we're just going in to fill in the blanks. One is a discussion of options for alternate care, whether that means home health, whether that's going to be a palliative referral, etc. Identification of their attending physician that's going to take over care after the discharge. We must identify an attending physician. So whether that's their family doctor that they're going back to, maybe they haven't been the attending, but now that they're coming off a hospice, they're going to start going back to that hospice, that physician. So we need to identify who that is, and we need to ask the patient and the family who that doctor is going to be, so we can document that. Assessment and discussion of plan for DME. If the patient needs, obtain a physician order and submit it to the DME company of their choice or whatever their insurance covers. Ensure that our DME is not picked up until the patient has DME replacement delivered. Number 4, if the patient's in a facility, communication with that facility and delivery of the notice of discharge for anticipated date. Include the facility contact in the documentation, right? So identify that person who you are communicating with, whether it's Tammy, who's the director of nurses, or Stephanie, that's the ADON. It doesn't matter. Identify that person and their position and the day that we gave them that notification. Education provided on medications, treatment, signs and symptoms of decline, skincare, nutrition. So, what education are we delivering as we prepare to discharge this patient? Planned date of discharge. Again, it has to be 5 days after we deliver that notice of Medicare non coverage. And then discharge planning will be discontinued if the patient condition declines and meets eligibility requirements. That verbiage is already in that note template, so you don't have to type it all in. It's just sitting there. And so you just don't do anything with that, leave it be. And then hospice will assess for readmission if the patient condition declines after discharge. Another piece that is in that template already, you won't have to do anything with it. The verbiage is already there. So that's why I say use that discharge planning template in your coordination notes, and you'll capture everything that, as a compliance department, we need captured. The next step is for the PCM. Complete the following forms for the team member to deliver at least 5 days in advance. That notice of Medicare non-coverage, which we call the NOM-NOC, that's that 5-day notice. A detailed explanation of non-coverage with that NOM-NOC. Discharge, change in designated hospice form. A Medicaid 3071 form needs to be completed, and a discharge notification for facility patients, right? That is just a form that we leave for the facility and that we document and we get a copy of. So we have a copy of documentation saying, yes, we can prove that we gave notification to the facility as well. So the PCMs to get all of that paperwork together and ready for delivery by the RN case manager. And then the PCM will schedule an RN 18, which is a discharge visit for that RN case manager on the date of discharge. And then the RN case manager, upon discharge, when we're doing that RN 18, right, order a 2-week supply of medications and supplies, arrange for pickup of the DME if applicable at the date of discharge. So remember, we're going to try to coordinate their new DME coming in. And so that may take a little longer than that 5 days, and we will take care of that. We will allow that equipment to be there in a reasonable amount of time to cover the time that they discharge and they get their new equipment from where we're ordering it. And then the next steps are for the PCM, complete that discharge workflow in home care home base. If it's a skilled nursing facility, click the name of that patient to the senior director. So Audie or Gay. Intake will follow up on that patient via the facility in case of decline after discharge. If they're in any other setting other than skilled nursing, receive permission from the patient or representative for a palliative program eval. And so they can follow up and then email Kim Nix at knix@chot.org for scheduling of that palliative referral to be evaluated. Then review the discharge summary coordination note and send that discharge summary to the physician that's going to be taking over care for the patient. And just an aside and a caution, this may not be the attending physician we have on file in the chart, right? So they may have picked a different physician. They may not be seeing their regular physician or the referral physician. So they need to let us know what physician they're going to go to so we can send that notice over and those records over to that attending physician. And then finally complete that discharge workflow in home care home base. And that is everything for the process. So let's just take a quick look at the checklist. And the checklist, you'll notice, mirrors very closely that process, right? And this is so we can ensure that every step of that is done. So, PCMs, if you will print yourself out a copy of this checklist, and once we identify we are discharge planning a patient, go ahead and start and keep this checklist for the patient. It's fine to go ahead and print a copy out to give to the case manager as well. So they have it as a reference as well. Again, we're just going to go through this real quick. Just mirrors almost identically the process. The team is going to discuss that eligibility in IDG. The RN case manager is going to contact that attending physician for discussion and request any other documentation. And they're going to document that conversation and put this verbiage: patients under review for ongoing eligibility. The RN case manager is going to complete that RN2 or a routine visit if an RN2 has already been done together with another nurse or a nurse practitioner to assess for eligibility. The reason why we're asking a nurse practitioner or another nurse to assist and do an evaluation and assessment in tandem is because two sets of eyes are better than one. And I can tell you, as a case manager who has gone through this process, especially with patients that are struggling with decline, right? Alzheimer's patients, Parkinson's patients, those dementia patients that just have that slow decline, it's always good to get a second pair of eyes. We see these patients every week, sometimes multiple times a week, and sometimes we're the only nurse seeing that patient. And I can become, you can become, we can all become a little blind, right, to some of the things that we see because we're seeing them so often. Just like the family, sometimes we point out decline to them that they haven't even noticed or hasn't registered with them. Same thing as professionals. Sometimes we just need a second set of eyes. So that's what we're doing here. Then we're going to document that conversation with the patient or representative that eligibility review is underway. We're going to let them know, hey, we are looking at possibly discharging mom, dad, right? Whoever that patient is. And here's why. And explain that to them and document it. Again, PCM, you're going to arrange for that face to face visit to be completed ASAP. And then on the checklist, we have a place for you to put the face to face date once you schedule that. Report findings and send documentation in an email to the hospice physician, so their team physician and Dr. Capper, for final review and guidance. The case manager, then, once we know that we're going to be moving forward with discharge, is going to write and order discharge planning to begin today for expected live discharge on whatever that calculated date is. Then the RN case manager has these tasks. Again, this is that discharge planning coordination note. So I'm not going to read all these things to you. The template, again, has all these pieces in there. So if you just use that template in your coordination note, then you will have all these pieces. If not, then use the checklist. I don't know why you wouldn't want to use the template, but make sure that all these pieces are on there in there. Again, some very important pieces at the very bottom here: discharge planning to be continued if the patient's condition declines and meets eligibility requirements, and hospice to assess for readmission to patient's condition declines after discharge. Those pieces, again, are all in that template, so you don't need to type that in. Just use that template. The next pieces are for the PCM. Complete those following forms. We already talked about those forms. So the PCM is going to complete those forms and get them ready and give them to the RN case manager to deliver that 5-day notice. And then on the date of discharge, the RN case manager, again, is going to do that RN18. They're going to do a 2-week supply of medications. You're going to arrange for pickup of the DME if we can at that point. We're going to place a physician order in to the chart saying discharge patient from hospice due to extended prognosis. If you just use that verbiage in an order, that's the order, right? That's it. Sync that order and then complete a discharge summary coordination note. And you guys all know and have done those, I'm sure. PCMs are going to then complete all the workflow tasks. They're going to, if the patient's in a skilled nursing facility, click the name of that patient to parish. If they are in any other setting, they can be referred to palliative. and that would be through Kim Nix, and her email is there. Review discharge summary coordination note by the TA. This is the TA's task is the very end. They're going to review that discharge summary coordination note to make sure it's complete and send the discharge summary to the physician that's been chosen to take over care of that patient, and then complete any of their discharge workflow. So that is it. That is your process and your checklist. PCMs and directors, I have updated these right with some of the newer stuff. The palliative is in there instead of pathways we don't have anymore. So these forms have been updated and they are in the clinical drive under clinical forms, and then live discharges and live discharges. So if you need help finding that, I can help you find it. Thanks, everybody. Hope you guys have a great day. If you have any questions, don't hesitate to reach out and we'll take care of those in the compliance department. Y'all have a great day. We'll talk to you later.